All right. Hello, everybody, and welcome to another episode of Move with a Doc. I'm Dr. Rupa Shah. I'm a family physician who's had over 20 years of experience in family medicine and clinical experience. And as always, we've structured these talks where the goal is really for you to take a quick break out of your day and get a little bit of movement incorporated into your day. So feel free to move, stretch, take a walk, anything just to get your muscles moving today. And today we're going to talk about a topic that affects all women who have had periods in their life at some point. And so we're going to talk about menopause today. So this is always a super popular discussion in my office and one that brings up so many questions for my patients. And I do love talking about it. Also personally, because I'm going through perimenopause, so it's very timely. And a lot of the things that my patients have taught me over the years of symptoms that they've experienced has kind of given me just, what to look forward to. And so as I'm experiencing those, I'm like, oh yeah, I knew this was coming, sort of thing. So I'm going to try and touch on some of the highlights that this phase of life can often bring women, and some of the things that we can do as women to help manage the symptoms as they arise, or if you are a partner to someone who is going through this, also this can be really helpful as well, and you can pass along to your partner. So I think there is always a little bit of confusion when we talk about what is menopause? Actually, what is menopause? So menopause, as the name implies, is the pausing, is the cessation of your menstrual cycles. It's the end of your fertility, or we can call it the end of your reproductive years when you can no longer get pregnant. So we use this definition specifically when you have not had a period, not had a menstrual period for 12 months. So that's sort of a key distinguishing factor. You have had to have gone a full 12 months, a full year of no period, no menstrual bleeding, and then you are considered to be in menopause, okay? What is happening? Let me back up one second, because I'll just mention this here before, in case I forget, because this is something I always want to stress to my patients. So I just said it's a full year, 12 months without any bleeding. And I just want to say that any bleeding, including any spotting that you have after that 12-month period of time, is considered abnormal. And even if it's one day of spotting in your underwear, on your panty liner, talk to your physician about it, because that does deserve further evaluation. So I just did want to mention that. But what is happening during menopause? So what's actually happening on a physiologic level is that your ovaries are now making less estrogen. And that's what's leading to the cessation of the periods and all the symptoms that can sort of arise. And you've been making estrogen ever since you hit puberty. Your ovaries have been working for you, making estrogen and secreting it into your body. As you begin to make less estrogen, this is the period of time you're going to start noticing those changes in your menstrual cycle. And this can be from anything from how long the periods themselves last, how heavy they can be, the duration between the periods, meaning how long those cycles are. Typically, women are on like a 28, 29-day cycle, and you'll start seeing some changes in that as well. So let's think about it in stages. The first stage is actually perimenopause. So before you actually stop having absolute periods, you're in perimenopause. And this is an interesting phase because this can be very variable in how long it lasts. So perimenopause can actually begin about 8 to 10 years before menopause. And again, this is the period of time your ovaries are starting to decrease the amount of estrogen they make. So this will usually start in a woman's 40s, okay? But typically about like ages 45 to 55 is that perimenopausal phase. But some of these changes can start as early as 40, and even I've seen late 30s, okay? And that perimenopausal period lasts right up until menopause, the point where the ovaries have actually stopped making any eggs and any estrogen. So in the last 1 to 2 years of perimenopause is sort of the most dramatic drop in estrogen. And that's when you'll see a lot more of these changes, a lot of those menopausal symptoms. You're still having menstrual cycles though in perimenopause. So it's important to realize you can still get pregnant. You still may be fertile. You may be kicking out a couple of eggs. So you do need birth control at this phase, okay? Next, then, like I mentioned, you're going to move into menopause. This is the point where you stop having periods. And at this stage, your ovaries have stopped releasing eggs. You aren't going to be able to get pregnant, and they're not producing estrogen any longer. And then again, I mentioned it earlier, and I started out the talk saying menopause is when you've had no menstrual cycles for 12 months. And then again, any bleeding, spotting, etc., that you have after that is considered abnormal. And I encourage you to talk to your provider about that. And then the final stage is postmenopause and living life after menopause. So this is sort of the time period we refer to after you've gone that full year and you're in, postmenopause. You can still have some hot flashes, but hopefully these have eased up for a lot of people. Some people, unfortunately, and I've seen this in my own patient population, will continue to have a lot of those menopausal symptoms well into postmenopause. This is also the stage now that women have lost their estrogen and you're now at risk for certain diseases, including osteoporosis and heart disease, okay? So I'll mention quick, there is a condition called premature menopause, or we refer to this sometimes as premature ovarian failure, because remember, menopause is all about your ovaries not producing estrogen. And in sort of this abnormal stage where some women's ovaries kind of quit on them a bit earlier, we call this premature ovarian failure. And this usually occurs less than age 40. And then we also have a term called early menopause, where women between ages 40 and 45 actually go through menopause. So that's not actually abnormal. We just refer to that as an earlier development of menopause, because most women in this country go through menopause at about age 51, sort of the average age. Okay, so let's move into what are some of the symptoms and signs that you're going to start seeing. So I mentioned it earlier, you're going to start seeing your periods and your cycles changing. One of the first signs that you'll see, and I've seen this in my practice too, is that your cycles will actually shorten. So remember I mentioned like they are typically 28, 29 days. And if you're mapping your cycles, you'll notice that they're coming a little bit closer together. So they might be like 26 or 27 days if you're mapping them. And then eventually, after they've shortened a little bit, then you'll start seeing them lengthen. So you might go 40 days, 45, 50, and then eventually you'll start skipping periods altogether and then they'll stop. And that's sort of that whole perimenopausal phase leading up to menopause. Again, your periods at this stage in perimenopause, you can see them be heavier. You may see more clots. They can be longer in duration, meaning how many days you bleed. They can also be shorter in duration. You might start getting more PMS symptoms. This is a really common thing that I see. Women will start having more breast tenderness, more cramping, things that were really reminiscent of when you first went had puberty and had your menarche for the first time. So some of those things can kind of come back where the symptoms are really amplified. One of the biggest symptoms and kind of complaints that I get from women in the office are what we're going to refer to as vasomotor symptoms. And you know these as hot flashes, those dreaded hot flashes, night sweats. Some people call them flushing, whatever you want to call them. It's that sense of heat sort of rising up, can rise up from the feet. Some people say up into the chest, all the way up to your head. People can soak their night clothes at night. They'll have to change. Women have to sleep with fans. I mean, really, it can be a very wide spectrum of how bad and how severe these vasomotor symptoms or these hot flashes can be. But one of the things they can do really is interfere with your sleep quality, can also lead to irritability, difficulty concentrating, and really, for a lot of women, really affect their quality of life. On average, according to the consensus statement paper from the North American Menopausal Society that I just read, was very enlightening. These symptoms for most women last on average of 7.4 years. Okay, but that's not going to hold true for everybody. In fact, there are a lot of women that can continue to have their hot flashes even once they're in menopause, when in fact for the typical is that those should really lessen. Another kind of complaint that I see is insomnia, difficulty sleeping. This is all part of that perimenopausal phase. Poor sleep quality, again, can be associated with mood fluctuations, problems with your memory, not being able to focus, not being able to concentrate at work. We also know that poor sleep is associated with metabolic syndrome, associated with obesity, and then of course, other cardiovascular risk factors as well. We know that when women and anyone in general actually has poor sleep duration and poor sleep quality, this has been associated with a greater cardiovascular disease risk as well. So sleep is very important, and this is one of the things that perimenopause really can affect for women. Next, I want to mention the genitourinary symptoms, and these are actually quite common as well, something I see a lot of. So these are directly related to the estrogen deficiency. Okay, we mentioned that your ovaries start making less estrogen, but this has an effect on your vaginal tissue. And some of these symptoms you can start noticing are changes to your labia, the vagina, your urethra actually, and even your bladder, okay? So the most common symptom most women have is the vulvovaginal atrophy, and that vaginal dryness is what we're talking about here. So you get that dryness, it can feel like burning down there, it can be irritated. You can also have decreased lubrication with sexual intercourse, pain with sexual activity. These are all really common things that women can experience as they're going through this stage, and definitely in the postmenopausal phase. A lot of women actually can even get urinary symptoms where they have just a lot of urgency, burning, and even recurrent urinary tract infections. So this is a common thing I see a lot in my office, where women will say, I've been having so many more urinary tract infections. I haven't had these since I was a teenager. Yes, because the tissue down there is changing. You're losing estrogen, the tissue's becoming drier, and this in and of itself can lead to more urinary tract infections, and there is treatment for that. Other changes that we see, of course, emotional changes, I mentioned irritability, mood swings, even mild depression. Some of these will be related to the insomnia and the sleep, but some of these can actually just be as part of the perimenopausal symptoms. We can get dry skin, dry eyes, dry mouth, and then just some other symptoms that women can get. People have experienced, and I've seen this, racing heart, headaches, joint aches, stiffness, changes in sex drive, lowered libido, difficulty concentrating, memory lapses, feeling like you're just not thinking clearly, that fear that am I developing dementia because I'm more forgetful, the dreaded weight gain, we do see this, and then hair loss and hair thinning is another one. Okay, so we've talked a lot about symptoms, and you may be listening and thinking, boy, I have a lot of those that she just mentioned. So then the next obvious question is, what can I do about it? What are the treatments that are out there for me? So we have a lot of data, and I just want to reference this because it's a very popular, it was a very large study that was done, but it's called the Women's Health Initiative. And it was a very large randomized controlled trial of hormone replacement therapy in women that were aged 50 to about 79. And I just want to mention this, hormone replacement therapy is not for every woman or every person. It does have to be really carefully discussed with your physician. But in this large women's health initiative study, what they did is they used oral estrogen, which was conjugated equine estrogen at 0.625. And this is important because they only used a very specific dose in this huge study. So they used conjugated equine estrogen, 0.625 with medroxyprogesterone, 2.5 milligrams. And I mention this because there may be a role for certain women to try what we call HRT, hormone replacement therapy. I'm just going to mention this quick and run through some of this, but you have to use estrogen and progesterone together if you have a uterus still. We cannot use estrogen by itself because chronic, what we call unopposed estrogen or estrogen by itself can cause increased risk of uterine lining thickening and then can lead to uterine cancer or what we call endometrial cancer. The goal is to use the lowest effective dose that we can to treat the symptoms because there is still a lot of concern about side effects of hormone replacement therapy. There's some thought that some of the non-oral routes like transdermal patches, vaginal creams, and rings might be better, but there's no great studies on those forms on the risk of heart attack, stroke, breast cancer, and blood clots, what we call venous thromboembolism, so clotting. In the Women's Health Initiative, there was a higher incidence of breast cancer in the women that took the estrogen progesterone therapy compared to placebo, and it was a small absolute risk, but you have to keep that in mind when you're talking to your physician about that. There was also small increased risks of coronary events, thromboembolism, the blood clots again, stroke, breast cancer, and gallbladder disease. So it has slightly gone out of vogue. We don't use a lot of hormone replacement therapy because there's still a lot of questions and concerns about the risks involved. Some absolute risks for people that absolutely cannot use oral or transdermal hormone replacement. If you've had unexplained vaginal bleeding, liver disease, prior estrogen sensitive cancers like breast cancer, prior heart disease, stroke, heart attack, venous thromboembolism, meaning the blood clots, or gallbladder disease. Okay, so I'm just going to throw that out there, just food for thought. But that's something to talk to your physician about. Okay, so what are some of the FDA approved indications for using the hormone replacement? Then you're thinking like, well, if it's got all these risks, like who should even think about using this? I think the women that should think about this are those that have really moderate to very severe vasomotor symptoms, those really terrible hot flashes and flushing that completely decrease your quality of life, impact your sleep, which then leads to the mood issues, the concentration, the memory problems. You might also want to consider it as a prevention for osteoporosis, but it is not FDA indicated for treatment of osteoporosis, so that's very important. There are some conditions where women have low hypoestrogenism, and that's a whole separate category. I won't get into that. And then again, treatment for very moderate to severe vulvovaginal symptoms, that vulvovaginal atrophy that we were talking about. So that's going to be a very small subset of women too. So I'm going to kind of break it down now just for the specific symptoms, because I think that's when women come to my office, that's what they want to know, because they're having a particular symptom that's the worst and they want to know what they can do for it. So for the vasomotor symptoms, the gold standard, like I said, for really severe is hormone replacement therapy. And again, you have to use it in the very lowest effective dose to avoid some of those increased risks for heart disease. We want to reserve it for healthy, and I'll say you have to be healthy, healthy symptomatic women less than age 60. They're really over the age of 60. These studies have not been done, and it can be a bit risky. Hormone replacement therapy can help improve sleep for women who are bothered by their vasomotor symptoms. But again, I'll just repeat it. You have to talk to your doctor about which formulation is going to be best, which dose is going to be best, and the route of administration. And you absolutely have to consider your family history of cardiovascular disease like heart attacks and strokes, your family history of venous thromboembolism, breast cancer risks, and your personal history of all of those things as well. There's controversy on when to stop hormone replacement therapy. Some people think between age 60 and 65, it's controversial, and you have to talk to your doctor about that as well. So and I'm going to get into a little bit later on too in the talk. I just wanted to talk a little bit about the HRT, but I'll talk about some other non-hormonal treatments later for those hot flashes later on too. Now, for the genitourinary symptoms, that vaginal dryness, a really effective treatment is vaginal estrogen therapy, okay? What is great about this formulation is that there's really minimal, what we call systemic absorption. So the amount of estrogen that you're absorbing into your bloodstream is small enough that we feel that there is not a huge risk to you personally for heart attack, stroke, breast cancer, thromboembolism. You would insert these products typically into the lower third of the vagina. Okay, the lower third versus the upper third as you get closer to the cervix and the uterus. And there's some thought that that's better for number one, the genitourinary symptoms is closer to the vagina and the urethra, and that also you're getting less estradiol absorption systemically that way. So the lower third is best for those treatments. If you have a history of breast cancer, you have to talk to your oncologist even about vaginal preparations. For urinary tract symptoms, I mentioned some women get a lot of frequent UTIs, they might have urgency. The thought is that the vaginal estrogen therapy actually increases blood flow and blood vessels around the urethra and may actually improve collagen synthesis and improve that vaginal epithelium. So a lot of kind of neat effects that it can have. Systemic and low dose vaginal estrogen therapy may be effective for some of the sexual problems by increasing, again, lubrication, blood flow, sensation. There's some thought that for low libido, some of the transdermal patches may be helpful, but again, they come with their risks, so you have to talk to your provider about that. Okay, so I want to talk about, this might be a little controversial, but compounded bioidentical hormones, because I do get this question quite a bit in the office, and it is a hard question to answer. And I know a lot of women are looking for treatments and options to treat their hot flashes, their vaginal dryness, their libido, all of these symptoms that are affecting them during that perimenopausal, menopausal phase. So I want to talk about bioidentical hormones because you get a lot of questions out there and there's a lot of people offering this. So bioidentical means what's really similar to what our ovaries make, our endogenous estrogen. But the term can be really misleading, okay? There are what we call government approved, meaning like the United States, the FDA has approved bioidentical hormones, including estradiol, estrone, and medroxyprogesterone. Okay, so these are what is approved by the FDA. These are regulated, they're monitored for their purity, their efficacy, and their safety. Now, in contrast, when you go to what's called a compounding pharmacy, and there are many in the area and they are reputable, the compounded bioidentical hormone therapies that are prepared by a compounding pharmacist, they do use a provider's prescription, but they combine different hormones, okay? They combine estradiol, estrone, estriol, DHEA, testosterone, progesterone, okay? And they're using untested, unapproved combinations or formulations, okay? So I just want to put that out there. These can be administered then in very non-standard, untested routes, like subdermal implants, pellets, and troches, okay? And a lot of times these will get prescribed by a prescriber based on serum, so blood, hormone testing, salivary from your, cheek, saliva testing, and then even urine hormone testing, okay? So I just want to put out there, these are unreliable. And the reason is because there's a lot of differences in hormone pharmacokinetics, hormone absorption. There's also what we call diurnal variation. So depending on the time that you took your sample, morning, midday, afternoon, evening, and there's a lot of individual variability as well. So that sort of testing is really unreliable. There's also not much safety and efficacy data, and there's really little to none high quality pharmacokinetic data on the safety and efficacy of compounded bioidentical hormone therapy. So I'm just going to say that. So they do present a safety concern because of the minimal government regulation, monitoring. You can get overdosed, underdosed. There can be impurities, lack of sterility, lack of scientific efficacy for sure, lack of safety data, and lack of labels outlining the risks of treatment, okay? So I'll just say it one last time. Salivary, urine, hormone testing to determine what type of dosing that your pharmacist should compound for you is very unreliable and not typically not recommended, I would say. And serum hormone testing, meaning blood hormone testing, is rarely needed. There's probably a few indications. I can talk about that later. So let's briefly kind of end. I know this one went a little long, but there just is a lot to talk about. So I want to end with what the majority of women, and someone like me, what could I do? Some non-hormonal complementary alternative treatments for treating the symptoms of menopause, because eventually people are going to have hot flashes, or you may be having them. You might be noticing some of the vaginal symptoms, the dryness, the recurrent infections. So what are some botanical supplements you can do? So I'll name a few of them, and these can be bought at some of the health food stores and things like that. But black cohosh has had just long history of being useful for hot flashes. Dong Quai, evening primrose will come up again and again as an herbal that can help with hot flashes. Ginseng, phytoestrogen. So you'll hear that a lot. So that's plant-based, soy products, okay? Those can be helpful for obvious reasons with some of the hot flashing. Valerian root can be helpful for hot flashes, even helping with insomnia and sleep. And there's some reports that flaxseed, probably some of that omega-3 is helpful with some of the hot flashing as well. Non-botanicals, melatonin, you've heard this before, of course, can help with sleep, insomnia. I'm going to throw in CBD. I think CBD, we've talked about this before too, can be really great for sleep-related, maybe even some of that joint stiffness and aching people get. So it may be worth a trying some of the CBD gummies to see if they're helpful. Acupuncture, mindfulness, women have turned to this when some of their symptoms get really bad. And don't forget about good old-fashioned exercise. There have been reports that women that exercise and do aerobic activity for at least 30 minutes, 4 to 5 times a week, have less severity and less frequency of hot flashes and their what we call those vasomotor symptoms. And then, of course, a healthy diet, lowering your alcohol consumption has been shown to be helpful with the menopausal symptoms. So now let's move into medication treatment. Not talking about hormone replacement, just other medications that we can use. Gabapentin, some of you may have heard of this. It's useful for a lot of different conditions, but again, it has been shown to be helpful for hot flashes and improving sleep. Some of the side effects, quick mention, mental fogginess, difficulty concentrating, memory issues as you get into the higher doses. But if you can stick to the lower doses, you might find some improvement for your symptoms. And then my favorite, and the one that I use a lot in my patients, are the selective serotonin reuptake inhibitors. You know them as the SSRIs, things like Prozac, Lexapro, citalopram, Zoloft. That increased serotonin does help with the hot flashes specifically. So it can help with the frequency and the intensity of the hot flashes, so you can kind of get through the worst period of the hot flashes. But I've also seen it help with people's sleep. And then, of course, it is useful with the moodiness, the irritability, and those mild depressive symptoms that a lot of women experience also. I wanted to end, and sorry if I'm going over a little bit, I'll take questions at the end, but I wanted to end with some questions that I had received earlier, and because they're questions that I always get from my patients. So I'll get right into it. Number one, weight gain. So a lot of women ask, like, why is this happening? Why am I gaining weight? You know, is it hormonal? What can I do? How can I balance my hormones? And there's a lot of folks out there, a lot of providers, alternative providers, who will say they will give you that perfect supplement that will balance your hormones. So what does that mean? We can't really balance our hormones. I just told you, it's about that decreasing estrogen that's causing a lot of these changes. There was an interesting study that came out, and I always sort of hate to, kind of mention this one, but our metabolism, they actually really studied women's metabolism during menopause to see if it truly slowed down our basal metabolic rate, and it does not. So I know we always say our metabolism slows down as we go older. It does not, but there are obviously a lot of hormonal changes that occur that do affect our weight in menopause. So I always try and go back to most of the things I just mentioned in my talk for women that gain weight during menopause. Let's get back to the basics first: a healthy diet, good sleep. We know that altered sleep duration and quality can cause alterations in our hunger hormones, and a lot of hormonal activity in the hypothalamus that can lead to weight gain. So go back to the good sleep, good diet, and stress. So stress reduction. We know that an increased cortisol level, chronic stress, can lead to increased hunger hormones and weight gain during this time of life too. So it is a complicated time of life. I don't try to say I have the answers for why women gain weight. It is a phenomenon I see a lot. I would just be really leery of folks that are trying to say they're going to balance your hormones with X, Y, or Z supplement, because that is not always the right answer. Also, always talk to your physician if you are gaining weight. Hypothyroidism is a condition we see a lot during perimenopause, so make sure you get some of that laboratory testing done too. The other one I get from women is, why am I fatigued? I've been tested for all the causes. I'm perimenopausal and I'm just really fatigued. And is this a symptom of perimenopause? And I think it is. And I think for all those reasons I just mentioned, you can be having some vasomotor symptoms, night sweats that might be affecting your quality of sleep. That's going to lead to fatigue. We know muscle mass slightly decreases also during aging. So make sure you're staying up with strength training. Strength training also helps with osteoporosis, will help sort of combat some of that fatigue we might be feeling as well. There's just a lot of causes for fatigue. So make sure you talk to your physician, get the routine testing. If you're having excessive menstrual irregularity, having heavy periods and bleeding, you could be anemic. You want to get that tested. You want to be checked for hypothyroidism. And once you've had that workup done and you're still fatigued, I agree, some of that could be due to some of the perimenopausal hormonal fluctuations that are occurring. Another question that I had, number 3, was, will these hot flashes ever go away? Again, I mentioned in the study, 7.4 years is the average, but there are women that are 10 plus years, into having hot flashes, and they're postmenopausal and they're still having hot flashes. And that can be, some of that's hereditary. If your mother, sisters also had a very prolonged history of hot flashes, then you may also be just genetically more predisposed to having those, unfortunately. Number 4, the brain fog. I mentioned this. It is a part of perimenopause. You will feel more forgetful. You may feel like you can't concentrate. You may have that tip of the tongue phenomenon where you feel like that name is right there, but I can't think of it. I know one year I lost where I hid my Christmas presents for my husband, and I was super upset because I, hid them in July. And when December came along, I was like, for the life of me, can't remember where I hid those. So yes, that does happen. What can you do about it? I'll go back to the basics. Really optimize your sleep. Sleep is when our brains regenerate. Diet, make sure you focus on an anti-inflammatory diet with lots of fruits and vegetables, omega-3s for that good brain function. And then again, we talked about some of the treatments you can talk to your physician about, including HRT, SSRIs. There are some things to potentially help with some of that brain fog. And there's some nice supplements out there too, like I mentioned, that have some of those valerian root and soy and things, and some of those may be helpful to women to try. But always go back to make sure you sleep well, make sure you're exercising, because when you exercise, you're getting blood flow to your brain. Yes, I have brain fog. And you want to keep up with those things as you go through that perimenopausal phase, and you want to keep up your muscle strength as well. And then I think I answered this 5th question, but is there anything that you can take to help? Supplements and foods. I mentioned the supplements you can take, but foods, you really, here is the time of your life you want to focus on a nice anti-inflammatory diet, not a lot of sugars, sugar sweetened beverages, unprocessed foods. All of that is going to lead to more inflammation. Inflammation is going to lead to more of these vasomotor symptoms, hot flashes, brain fog, fatigue. So you really want to optimize the things that you can optimize in your life. And the last question that I just thought of that I get all the time is my patients coming in saying, I want you to check my hormones. And they're mid-40s. And the reason your physician is going to say no is because they're not helpful. Definitely, and I mentioned this, urine hormone testing, not helpful at all. Salivary hormone testing, not helpful at all. But serum or blood hormone testing, not helpful. And the hormones I'm talking about are your estradiol levels, your estrogen levels, your FSH, and your LH. And the reason is when you're in perimenopause, there is a wide range of normal in a menstruating female. Those hormone levels are actually not helpful until you are in menopause, until you've not had periods. But at that point, it's almost like you're in menopause because you haven't had a period for 4 months. And at that point, it can be helpful to check those hormones because your estrogen levels, your estradiol levels should be very low, okay, under the limit of normal. And your FSH and your LH levels will be very high because those are coming from the brain. They're telling your ovaries, the follicular stimulating hormone and the luteinizing hormone, the FSH and LH, are telling your ovaries, kick out some estrogen. They're super, but your ovaries are saying, I don't have any left. I've used it all up. And the result of that is you're not having periods. So by the time it's useful to check hormones, you generally already have a sense that you're in menopause. And any time before that you want to get your hormones checked, I can nearly guarantee you they're not going to be a useful indicator of where you are in your perimenopausal journey. So it's not that physicians are trying to not be helpful or not cognizant of what you're going through and sympathetic and empathetic. It's that the science doesn't show that checking those female hormone levels are useful. What is useful? Checking thyroid hormones, because that is something we see in perimenopause, checking your hemoglobin, your iron studies, your ferritin. These are useful if you're having abnormalities in your menstrual cycles, because those can lead to fatigue, problems with concentration, memory, all of those things. And those are helpful. But I will just say that checking your female hormones, not helpful until it's obvious to both parties that you're already in menopause. And at that point, we can check them, but it's to confirm what we already generally know. So with that, I will end. I've gone on way too long today, but it's a super interesting topic. Thank you for joining me, and I will see you next time.